Okay, good evening, everybody. Welcome to the webinar. Thank you for being here with us tonight. Tonight we're having a webinar sponsored by Linnea. I want to thank Linnea for sponsoring this very interesting webinar in a topic that is actually my passion, which is hysteroscopy. Tonight with me, by the way, I'm Jose Tony Carugno. I'm the Minimal Invasive Gynecology Director of the University of Miami. And with me tonight, I have two co-speakers who need no introduction, Dr. Keith Isaacson and Linnea Goodman. Keith, you mind introducing yourself?
Hi, and I want to thank Tony for inviting me, as well as Lena and the AAGL for hosting this. But my name's Keith Isaacson. I have been in practice in Boston for the last 35 years and was a director of the fellowship program there at minimally invasive GYN surgery, and just recently moved to New Orleans in October of this past year to be closer to my wicked cute grandson. So I look forward to listening to the talks, and thank you for the participation.
Hi, I'm Linnea Goodman. Super excited to be here tonight. And I did my training at UNC Chapel Hill and then fellowship at Cleveland Clinic. My first job out of fellowship as a reproductive endocrinologist and infertility specialist was at RMA, New Jersey in private practice. And there I specialized in reproductive surgery and did a large amount of surgery for that practice. So kind of a huge volume surgical practice. And then transitioned back to academics at UNC and was there for a number of years. And then most recently, I have been at Virginia Fertility and IVF in Charlottesville, Virginia in private practice, but I am affiliated with the University of Virginia. And so do RAI and work with the residents and still do a fair amount of surgery. So excited to be here today and to hear this webinar.
Very, very good. So a couple of housekeeping issues before we start, so you know what to expect. We're going to have a brief presentation, each one of us. And then at the end, we're going to have what I consider is the best part of the webinar, which is a long Q&A session. Please, if you have any question, put it on the Q&A session of the Zoom. So we'll try to answer as many questions as you have. If any question remain unanswered, rest assured we'll get to them through email or something, but everybody will have their questions answered. And with that, we're going to start. So no financial conflict. And when I was asked to lead this webinar, two questions came to my mind. The first question is, why should we adopt actually hysteroscopy and abandon blind intrauterine procedures? And the second question is, well, assuming we are going to adopt hysteroscopy, why should we incorporate in-office hysteroscopy instead of going to the OR? And to answer that question, to answer the first question as to why we should abandon blind procedures, is this about 5 years ago, Dr. Frank Lawford put up this nice perspective article where he stated that the time has come to quit on relying blind biopsies or DNCs for the diagnosis of cancer. The National Institute of Health of the UK put up these guidelines, and in their guidelines, they stated like this: importantly, blind endometrial biopsies should no longer be offered to women with symptoms of heavy menstrual bleeding. So when you see organization putting these blunt statements like that, is because they have the scientific evidence behind them that allows them to do so. We, from the Global Community on Hysteroscopy, recently published a consensus with FIGO, which is the International Society of Gynecology and Oncology, where we kind of stated where's the current status of blind procedures. And in that statement, we made the recommendation that both FIGO and the Global Community on Hysteroscopy, it's a call to slowly decrease and eliminate blind procedures and adopt hysteroscopy as the first line. And hysteroscopy should be included in the evaluation of patients with suspected intrauterine pathology. Not only bleeding, any intrauterine pathology should be assessed by hysteroscopy with direct visualization. And blind procedures should slowly and gradually be replaced for in-office hysteroscopy with direct visualization. When we're talking about cancer, right, diagnosis of endometrial cancer, which is probably the reason number one of why we do endometrial biopsies and we evaluate the endometrial cavity. A recent study that we published that explain why endometrial biopsies with direct visualization with hysteroscopy should actually replace the blind procedures. And it's easy to understand. Basically, the rationale comes down to quality of the specimen. Two things. When you do the biopsy under direct visualization, the first thing is it's a targeted biopsy, right? You're biopsying the worst looking area of the endometrium. So all those endometrial cancer that are focal pathology, you no longer miss those. But most importantly, you are obtaining a piece of tissue as opposed to all those shredded tissue that you get when you do a biopsy, let's say, with a pipette. And what our study proved, one is the specimen was adequate 100% of the time, and it was concordant with the diagnosis also 100% of the time. So when you do the biopsy under direct visualization, you can rest assured that the type of cancer that you're going to determine is going to be accurate, especially if it's endometrioid type. But not only that, it could also give you the grade. So you can tell the pre-op, you can say that this patient has endometrial cancer, endometrioid type, and the grade of cancer. And you will know that that information is really important to have pre-op because the gynecologist, oncologist will plan their definitive surgery, which is the hysterectomy, accordingly. The European Society of Gynecology Oncology also recently put out a guideline for the fertility-sparing treatment of patients with endometrial carcinoma. We know that we're having this endometrial cancer in younger and younger patients, and some of them are looking fertility-sparing options. And see how in their recommendation, the very first recommendation is hysteroscopy guided endometrial biopsy is the preferred over blind biopsy for confirming the diagnosis of endometrial carcinoma. One more, this is really hot from the press. This study was published, these guidelines were published 2 weeks ago. It's the guideline of fertility sparing treatment of patients with endometrial carcinoma. And as you see, the very first step of the guideline states offer hysteroscopy for the diagnosis of endometrial cancer. That's the first step if you're considering doing fertility sparing treatment. So as you know, that there is solid evidence justify the use of hysteroscopy and abandoning the blind procedures. The second question, though, is why should we do it in office instead of the OR? Well, and the answer is because we can, because of surgical innovation. Surgical innovation over the last 15, 20 years probably changed the game of hysteroscopy, for lack of a better way of saying it. We went from not only the diameter of the hysteroscope that went down from 10 millimeters to less than half. Now we're going 3-4 millimeters. The diameter of the newer hysteroscopes, but it also changed the shape. It's no longer round. Now the hysteroscopes are oval, and that change in shape is really important because it allows you to align the bigger diameter of the hysteroscope with the bigger diameter of the cervix, and in that way you can introduce your hysteroscope into the uterus in a painless manner. So when you face office versus operating room, well, the office setting is obviously cheaper. We know that there's several studies that have proved that. It's very easy to schedule. If you need to schedule a patient in your office, you only need to tell your front desk to do so. The patient will come to a comfortable environment. It's the office that they always come to see you. You're operating in your own environment. There is no anesthesia risk. It allows you to continue to flow. You can be seeing patients of your day office patients, and you can do this hysteroscopy at the same time. So overall, the logistics are way easier when you do it in an office setting, and most importantly, there is higher patient satisfaction. DOR, we know it's more expensive, it's more cumbersome to schedule. When you go to the OR, you're away from your office, you cannot see patients. So there is many disadvantages. If we can do it in an office setting, it's ideal for the patient and for us. And that's the medical aspect. But now the financial aspect also, I'm just briefly going to touch on this, on the economics. In 2017, the reimbursement of in-office hysteroscopy went up 237%. What does that mean? That back in 2016, when we were doing a hysteroscopic, let's say with endometrial biopsy or a polypectomy, we were getting 11 RVUs. In 2017, it went up to 38 RVUs. But there is a caveat. This jump, this increase in revenue in RVUs, it's only if the procedure is done in an office setting. If you're doing the procedure in the operating room, you're not gonna get this advantage. So if it's so good, patients like it, the literature supports it, there is better reimbursement. Why are all the gynecologists doing this already? Why are we having a webinar tonight explaining how to bring the hysteroscopy into the office? It's because we acknowledge that to do in-office hysteroscopy, there are barriers. There are barriers that need to be overcome in order to safely and effectively perform in-office hysteroscopy. And the barriers are, first of all, you need to understand the concept, right? Understanding the real role of the benefit of doing direct visualization versus blind procedures, the cost of the equipment, infrastructures, lack of training, and I'm gonna go over these barriers in a second, one by one. Understanding the concept, I already proved it to you. There is the literature out there supporting that we should move away from blind procedures and we should do procedures on the direct visualization. The cost of the equipment is where you have to ask yourself, should I embark on buying reusable equipment, the tower, on all the equipment, or should I rely on these newer disposable hysteroscopes that are coming out in the market? And as we know, there are pros and cons of doing so. The disposable equipment, if you decide to go that route, is easier to use. There's minimal capital investment that is needed because you just buy the hysteroscope and that's it. There is no need to buy towers or cameras, things like that. There is no cleaning and sterilization anymore. You can do it in any room. You don't need a procedure room. You don't need a dedicated room. You don't need staff trained to do this. Listen, it basically comes down to this, because the other barrier is, well, you know, I never did an office hysteroscopy during my residency. I'm not going to start now as an attending to do something that I don't know how to do. Well, if we can do an endometrial biopsy with a pipette, if you can place an IUD, you can definitely do an in-office hysteroscopy, especially with these disposable scopes. I place these are the three. There's an IUD, in the middle is the operoscope, and to the right, it's a pipette device. They are exactly the same. So if we can introduce the other two, if we can introduce an IUD, if we can introduce a pipette without problem, you can introduce a hysteroscope in an office with the advantage that the other two you do blindly, the hysteroscope, you do it on the direct visualization. And the last barrier that you have is patient satisfaction, right? Pain. We worry. We're not going to torture the patients because they're not going to come back to our office. This is what you need to know. what causes pain during office hysteroscopy when you're doing with the patient awake? Three things. One is going through the cervix. The other is distending the uterine cavity. And the third thing that causes pain in an office setting when the patient is awake is touching the endometrial walls. So if you pay attention to those three steps, I can assure you, you can do office hysteroscopy. I'm not going to say pain-free, but in a very painless manner. So in conclusion, office hysteroscopy is safe, it's effective, it's well tolerated, it's very easy to implement, and it's beneficial for both providers and our patient. And you basically need to do it because it's just the right thing to do. We need to do it for them. And I want to conclude with my residents there on the left, seeing through the opera scope. This a couple of weeks ago, we had an in-training session, and those are my residents through the opera scope. With that, I'm going to stop sharing my slides. And Keith, you are welcome to start sharing yours.
All right. Thank you, Tony. Let me see that I can get to share this. Okay, so what I wanted to go through in the next 15 minutes or so is the use of office hysteroscopy in the infertile couple, and why I personally think I'm a reproductive endocrinologist now doing more IVF than I've ever done. And I think all patients who suffer from infertility, all couples should have office hysteroscopy as a routine part of their evaluation. And I'll go through the data as to why that is. So what is an infertility evaluation? It's fairly straightforward now. It's semen analysis, check for ovarian reserve, the tubal patency, and a uterine cavity assessment. And the pathology that impacts fertility includes polyps, fibroids, intrauterine adhesions, septum, adenomyosis, and proximal tubal occlusion. So all of these can be either diagnosed or managed with hysteroscopy in the office, with all the benefits that Tony had gone through. So how do you evaluate the uterine cavity? There's DNC, hysterosalpingogram, ultrasound, saline sonography, and office hysteroscopy. And so the question is, most people are doing saline sonography. Very few people are doing DNCs or just 2D ultrasounds to evaluate the cavity. But why do I think office hysteroscopy is better than sonohysteroscopy? Well, let's go through some of the data. So if you look at the diagnostic accuracy of saline sonography versus 2D ultrasound versus a hysterosalpingogram in patients with uterine cavity disease, this is one study, looked at 69 patients, all underwent all three procedures with hysteroscopy as the gold standard. What they found is if a patient has a polyp, that the saline sonography will essentially pick it up nearly 100% of the time. At least in this study, it was 100% of the time. Clearly, with 2D ultrasound and hysterosalpingogram, that's not the case. But how about other diagnoses? If you look at adhesions, and unfortunately, well, fortunately or unfortunately, I see a tremendous number of patients with Asherman syndrome, probably 10 couples a week in my practice. So it seems to be either it's more recognized or it's more prevalent. But you can see if you compare hysterosalpingogram, transvaginal sonography, and saline histogram versus hysteroscopy, the saline sonograms have a sensitivity of only 75% and a specificity of 93% compared to the hysteroscopy. So the hysteroscopy is much more accurate than a saline sonography for just about all pathologies other than uterine polyp. So should we be doing this in all patients before they go through IVF? Well, again, just going through some quick data before we get into some videos. This is one study where they looked at 866 cycles, 555 patients before their first IVF, 311 who had failed IVF cycles, and 40% of those patients had intrauterine pathology, which is higher than I would expect, but that's what's published. And Hinckley looked at 1,000 patients prior to in vitro fertilization who had office hysteroscopy, and 32% of those patients had polyps, 3% had myomas, 3% had adhesions. So there's a lot of pathology there. Again, the hysteroscopic findings, even when they've had a normal hysterosalpingogram or when they've had a prior ART failure, 33% of these patients had a abnormality in the uterine cavity, even with the normal hysterosalpingogram. So it makes sense if you can do this in your office, you can do it without anesthesia, you can do it where it takes literally about 2 to 3 minutes. It takes me less time to actually do a office hysteroscopy than a saline sonogram. It becomes the procedure of choice. And again, just more studies demonstrating that there's quite a bit of pathology that you'll pick up in the infertile patient, particularly those prior to going through in vitro fertilization, getting an embryo transfer. And those who have recurrent IVF failures, again, this is a study from 2004, they looked at 211 patients that had no hysteroscopy. They had a 21% pregnancy rate. 210 that had an office hysteroscopy. If they had a normal cavity, the pregnancy rate back then was 32%. Now you'd expect that to be much higher. And those who had their cavities repaired went from 26% to 30%. So again, it not only shows that you have an abnormality, but it shows that if you take care of the abnormality, you'll improve the pregnancy rates. And that's really what we're trying to do. So if we look at the equipment, as Tony has already gone through with you, the smaller the scope, the less uncomfortable it is. The scope should have two features on it. One is that it's a continuous flow scope. So that means you have an inflow and an outflow. Typically, the second feature should be that your outflow channel should be your working channel. And let me repeat that. Your outflow channel in which the fluid is coming back should be your working channel, because there is a scope out there in which your inflow channel is the working channel. And as soon as you put in your instrument, you will lose distension. So you want to make sure the outflow channel is the working channel. So again, if you're using a reusable, you need to have a whole cart. And then here's the advantage that Tony had already gone through with you if you're using a disposable. You just have to decide. And what Tony said is true. If you to do a hysteroscopy using the CPT code of 58558 and you do a biopsy, you get good reimbursement. However, if you don't do the biopsy, that reimbursement is closer to $300 or for the RVUs. Even if I do Asherman's, or if I do a myoma, or if I do a septum, again, I don't get the reimbursement that I get as if you do use 58558. So check that out in your own clinic to see what's financially reasonable for you. So the procedures that we can do in the office, we don't just look. Clearly, if you can tolerate getting the scope through the cervix, as Tony mentioned, then you might as well be able to do these other procedures, such as an endometrial biopsy, doing a polypectomy with just scissors and a grasper. You don't need a tissue shaving device to do a polypectomy. And these are reusable or disposable scissors and graspers. When you cut the polyp, there's no pain. Again, don't cut the myometrium, but if you cut the polyp, there's no pain. You can do a small myoma as long as you can get it out through the cervix. I do all my Ashermans in the office because, again, cutting scar tissue is painless. Putting the scope through the cervix is not painless, but cutting the scar tissue is. We'll do small septums in the office, and I'll show you one case. Since I can't show you all these, I'm just going to show you a case of lysis of adhesions and another case using the Linnea operoscope of removing products of conception in the office. Well, yeah, you'll see. So let's start with a little bit with Asherman's. This is just a slide to remind me to remember to mention with Asherman's syndrome. Again, what we don't want to do is remove these stem cells or at the basalis of the endometrium, the part that leads to Asherman's. So the etiology, we know that Asherman's is a lot more prevalent than we thought. It can happen after a first trimester miscarriage. It's much more likely after a postpartum hemorrhage with a DNC, but it can also happen even with C-sections, with myomectomies, and I've actually had some patients who've had it just with a IUD. It was unexpected. And the impact of fertility is obvious. There's risks of recurrent miscarriage, preterm labor, abnormal placentation, and pregnancy wastage up to 90%. So it's also a lot more common than you might imagine. It's prevalent in 6 to 20% of women with primary infertility, 25% with recurrent miscarriage. Again, 25 to 40% after a postpartum DNC. 6% of women who've had failed IVFs. For as far as myomectomies in France, they reported an intrauterine adhesion rate as high as 60%. However, we looked at our data in Boston, and it was closer to 6 to 9%, so much less common than what's reported in France. And 43% of women with Asherman's present with infertility. So when you're doing the surgery for this, please just use cold scissors. The basic premise here is minimize the damage to the normal endometrium. So do not use heat, do not use monopolar or bipolar energy, do not use laser energy, and definitely do not use any tissue shaver, because you're not trying to remove tissue when you're treating Asherman's, you're trying to separate the tissue. It's two walls that are stuck together. It's not that you've actually developed new tissue there. So if you remove tissue, typically you'll make things worse, and you might be into the myometrium. And please, please, please do not do visual DNCs. This is a case of an infertility patient where they did a visual DNC, where they took the MyoSure or TrueClear, one of the tissue shavers, shaved it off here, and I'll just tell you that they basically removed her entire endometrium. So there's no point in doing that. Do not do a visual DNC with a tissue shaver. The chance of Asherman's is just way too high. So here's one case we'll just go through. This 30-year-old patient had IVF pregnancy, lost at 23 weeks. She had one attempt at lysis of adhesions. She was considering a second IVF attempt. I start off with a 2D ultrasound just so I could see the endometrial echo, so I know that I have something to go to. I'll then switch to a 3D, which tells me that more than likely that her left cornua is going to be normal, and there's going to be scar tissue in the right. And then we'll proceed with the hysteroscopy. It's all done vaginoscopically. It's done in the office. And this is just taking you through the vaginoscopic approach. And we're going to just use the cold scissors. And just as expected, there's some scar tissue in the cervix. And just for the sake of time, and you'll have to bear with me, I'm going to fast forward this a little bit. And so, again, we're using 5 French instruments. So that means they're 1.3 millimeters in outer diameter. And since they do not have any type of energy associated with them, other than the energy of your hand, even if you perforate with that, you don't have to do anything as far as doing a laparoscopy or anything like that. It will heal fine. So then we open that up, and now we can get the scope inside. And I'll fast forward that a little bit. As expected, you can see the left cornua looks pretty normal. The right cornua is occluded. And the one thing I want you to think about here, when you have Asherman's, it's usually one wall is attached to the other wall. So you don't necessarily want to cut in the middle. You want to cut where it's attached. So what I suggest to you is to follow what you would think is normal endometrium, and then cut up here as opposed to cutting in the middle, because that's likely where it's attached. And I know my time is up, so I'm going to fast forward and just show you that once you identify the other tubal ostium, You feel really good. And then you just finish taking down the scar tissue. And I'll skip through that. And we'll skip through that. Now, this is a case of removing products to conception. Now, we didn't talk about uterine distension. I know Dr. Goodman, she'll talk to you. She hangs a bag. I always use a pressure bag. And I use a little pump that keeps the pressure at a constant pressure, which is a little disposable pump here. But I did this one in the OR just so I could videotape it on a larger screen. So bear with me. And then this is just using the operoscope, and it's done. You'll see we're doing it all vaginoscopically. Because it's in a surgery center, the patient had to be draped, so I apologize. It's an office hysteroscopy program, but it's the same procedure with the patient awake. And then, so we go in and you're doing your vaginoscopic procedure. And then I really just wanted to show, focus up here so you guys could see the procedure itself. So I go in with the scissors, and just like I like to detach the products of conception with the scissors before I start piecemealing it, because many times you'll see that it is fairly well attached to the myometrium. So we'll detach it with the scissors and then just pull it out with the graspers. So fairly straightforward, just takes just a few minutes for these retained products of conception. Actually, right now, it's at 4 minutes and 25 seconds to finish the whole thing. Lastly, I think if you do this in the office, be prepared for the worst. So what's the worst thing that can happen? What very commonly is we have some patients that get a vagal response. So you just want to be prepared for it. And the way we prepare for it, we actually borrowed our operating room crisis checklist and modified it for the office. And so what happens so let's say a patient gets vagal, and I'll just skip to the unstable bradycardia. So it basically takes you through step by step. What are you going to do? So you don't have to memorize anything. You can practice this. You know it's in your office. You call for a crisis. You start the oxygen, and then you say, okay, give atropine. Well, I don't remember how much atropine to give. So you go over here and it tells you, give the atropine, either 0.5 milligrams IV or 0.4 milligrams IM. And it takes you through step by step. So you just feel more comfortable that if you had a complication, fortunately they are rare, but they happen, particularly the vagal response that happen. And you're prepared for taking care of it, and have your office staff practice it. So about once a year, we would go through a simulation and just practice it so everybody's comfortable, because this will happen if you do enough cases. And I'll stop with that. Thank you very much. And I'd like to introduce Dr. Goodman to finish us up. Let me stop my sharing.
Thanks, Keith. I'm going to share my screen here. All right. All right, so we've now seen why we need to do office hysteroscopy. And so my goal right now is to give you really a step-by-step guide as to how to start that. So when I started in a private practice, I was doing very minimalist of tools. So this was when I came back to academics, and I saw this and I about had a heart attack, because the waste that we do in the operating room is out of control. And so when COVID hit, we then had this ability to kind of rethink everything that we did, because we didn't do telemed, and all of a sudden we're doing telemed, and we didn't used to wear masks in the operating room and in the hallway, and then we were supposed to do this. And so it gave us this opportunity to really make strides and make changes. So the question is, okay, now you want to do office hysteroscopy. How do you do this? So we got to think about the cost. We got to think about what your office looks like. We got to think about your staff. And so what are your first steps? So I will say that this is sponsored by Lena. However, I literally have tried every single system out there. I really love new technology. I love trying new products, and So every time something new comes out, I do test it and try it and see if there's something that I could incorporate it for. But this really is my favorite setup because it is so simple to use. And as Keith said, I keep it very simple with just a bag of fluids. So I have my bag of fluids, and then I have my tool. And so this is me setting up the upper scope for an actual case. So it comes in a disposable container. It then has a module that you can plug a USB in for videos and pictures. And then you can also plug that into a big screen on the wall, as you just saw Dr. Isaacson do. It has a battery pack, so it's completely self-powered. And then I hook it up to a liter of normal saline, and I just use IV tubing. And so this is, 59 cents. And you'll see here that I am using non-sterile gloves, and I don't drape the patient, and I just use a 13-gallon trash bag onto the patient. So I don't use a sterile drape. I don't use any fancy equipment. And so this is my entire setup, and I'm ready to go. So now I have my equipment, and who are we going to use this on? So one of the biggest questions that I get from residents and fellows when I'm teaching is, okay, I have these tools, I know what I'm doing. Now, who am I going to do this on? And it's really important to pick your patients wisely. And so you want to pick someone, especially when you start, you want to set yourself up for success. So when I first started hysteroscopy, I came into this very high volume surgical practice, and I was getting all these referrals to do hysteroscopies. And I was terrified that I was not going to be able to get into the uterus. And I'm supposed to be this hysteroscopic expert. And I was like, what if I can't get in? So I gave everyone Cytotec. So everyone got 200 micrograms the night before and 200 micrograms in the morning of. And people did great. And I never struggled, but they also got diarrhea and they had this extra medicine. And after about 100 cases, I was like, oh, I don't think I need Cytotec anymore. And so then I stopped probably about 10 years ago, and I haven't gone back. Now, if I have someone that I'm really worried about cervical stenosis, or they've done something before and someone hasn't been able to get in, then I will consider it. But for the most part, I do not pre-treat anyone. And then the next question is, what do you do for pain control? And for me, I actually start with none for everybody. And like we saw in the earlier presentations, the biggest touch point here is if you touch the area of the tissue, if you touch the cervix, if you have overdistension, if you touch the fundus. So whenever I'm talking patients through this, I say, my big goal is to not touch anything. If I can navigate through without touching you, your body will not freak out. As soon as you start touching the body realizes that someone is there, and it contracts down, and that causes the pain. So if you can be very stealthy through the cervix and into the uterus, that uterus won't contract and you'll have way less pain. Now, if you are worried about pain, there are many things that we can do. So you can pre-medicate. So you could give Motrin an hour before. You could give an anxiolytic. You can do a paracervical block. Now, you'll see in a second, I do vaginoscopy for everyone. So I don't put in a speculum. And so I don't have access to the cervix. And so I generally do not do any of these and just start with nothing. And then also for first cases, certainly conscious sedation, if you have it available, is a good way to learn. So let's talk a little bit about vaginoscopy. So this is doing a hysteroscopy without using the speculum. And this has been studied pretty extensively, which shows that it's very well tolerated and usually has reduction in pain scores, also faster times and lower incidences of these vagal responses. And so who are candidates for vaginoscopy? Really, everyone. I will say it does take a little bit of a learning curve, though. If you leave this webinar and you say, okay, I want to start vaginoscopy, I would initially choose patients that you are setting yourself up for success with. So I would have patients that you know well, that have low anxiety, that are going to be able to take a couple extra minutes, and you'll be able to talk with them and walk them through this and say, hey, I'm just navigating through the cervix. And so pick, multiparous patients or patients that you're sure are going to be a little bit easier to do first. So as we go in with the scope, I always say the same things to patients. And I say, you're going to feel the water come in. It's going to feel like you're peeing on yourself. You're not. And that's why we have the drape underneath. And so as we go in, you'll see the air bubbles come through, and now I'm going to be looking for the rugated folds of the vagina. As I go in, and this is why it's a little bit of a learning curve, because you have to get your bearings and you have to take a second to find your cervix. The cervix is going to be smooth, opposed to that rugated folds. Now, I usually tell patients you're going to feel, for my nulliparous patients, where they have very small cervices like this, I say you're going to feel 2 points that might be a little bit crampy. The first is going to be a pop right at the external os, and the second will be as we navigate through the internal os. So you can see here that these are the crypts of the cervix. And again, if you don't touch the cervix, there's very minimal pain. And so at this point, I'm just hanging a bag to gravity, and I will have my assistant in the room. It might be a medical student, it might be a nurse, it might be a CNA, help to give me a little pressure on that bag to distend that cervix. And so this is a case from start to finish. So again, we've just placed it in the vagina. I'm now navigating through to find my way. And you'll see that there's going to be some mucus, and then you're going to see the difference in the rugated folds of the vagina versus the cervix. Now I've seen this nubbin of the cervix, and so I'm going to find the external os. And so you're just using that fluid to wipe away the mucus. You see the crypts of the cervix. And on this operoscope, there is a little dial that you can turn that turns the aperture so you can find your way without touching any of the sides of the cervix. This is where I'm asking my assistant to pressurize the bag, and as she pressurizes it, then I'm able to see that internal os and very gently slide it through into the uterus. So this diagnostic scope, so it's a scope that's really great when you just want to see what's inside the uterus. If you're looking for, you know, things that any sort of pathology that you just want to see, it's a great scope for that. But it can also do things such as polyps. It can do adhesions. So these are, you know, some filmy adhesions that you can take down with the cold scissors, as Dr. Isaacson was talking about. And as he said, so these are all done completely awake. And the nice part about doing adhesions while someone is awake is that if someone feels it, you're in the wrong place, because as he said, adhesions don't have any pain. Same thing with septums. When I take down septums in the office, if a patient starts to feel it, I know that I'm then at a place that has good musculature and vasculature, and that is where I should stop cutting. And so it's a really great way to be able to do that together in conjunction with the patient. This is just a little retained products. And you can see here, just like Dr. Isaacson said, you can come in. Again, these are often very vascular. And so if it's a bigger one, taking down with scissors and getting it separated before you take it down with graspers. And so then here's the side-by-side comparison of these saline ultrasound with hysteroscopy. And so now I really go straight to hysteroscopy. We've talked about costs already, so I'm not going to go too much into this, but there has been such a big change in value-based healthcare. And so we've seen this in all setups of really paring down what we need, but we can actually do it even more efficiently in the office because we don't need drapes, we don't need sterile gloves, we can really pare down our equipment. This was a comparison that I did when I was making this pro forma for UNC, where I was saying, okay, how much can we save by taking these out of the office? And you can see that charges go way down for the patient, and cost to the system goes way down for the patient as well, which is really huge for them. We talked earlier about RVUs, and really just the reimbursement is so different for that 58558 if you're able to do it in the office. The nice part too is that a lot of my patients just have a copay. They come in and they pay $30 or $60. And so this is very different than not knowing what the giant bill they're going to get from the hospital is. And then finally, just in the 2 minutes I have left, I want to talk through some really exciting new frontiers that I've been doing for office hysteroscopy. And that is for pregnancy of unknown location. So we've known for a while that we can do retained products of conception, but I've started to use it in my IVF practice for patients that have a PUL. So this first case is a patient who had an embryo transfer, and her betas initially were good at 100, but they did not rise appropriately. At 5 weeks, when she had a scan, she had a possible small sac. We knew this was an abnormal pregnancy, but we didn't know if it was an abnormal intrauterine pregnancy or if this was something in the tube that would need methotrexate. And so I started doing office hysteroscopy for these patients. And again, vaginoscopy coming in really gently. And we can do this, the same day that we've realized this abnormal beta. And in this case, you can see that that tiny sac was in fact there, and we're able to remove it pretty easily. And then afterwards, watch that HCG fall and be able to know that we've taken care of this pregnancy, and she can go right to her next transfer instead of waiting the 3 months for the methotrexate. This is another patient. So this is one who conceived with a donor egg. And again, betas were rising inappropriately. Now, she had a really thin lining. And so methotrexate was given without, diagnostic in the beginning. And then it did not drop. So she was given methotrexate again. And then you'll see that in going in, she actually did have a small amount of products in the uterus. And once we were able to remove this, we were able to see a precipitous drop in her HCG values. And so presumably we could have actually avoided the 2 different methotrexate doses had we done this initially instead of giving the methotrexate. And then finally, this is the third case where this is a patient who had had a previous PUL and gotten methotrexate. Now she did have this big thickened stripe. So we were like, oh, is this an intrauterine pregnancy? But her betas were very low and they really plateaued. And so did an office hysteroscopy, and you can see this polypoid endometrium, which was making the lining thick on ultrasound, but there was no gestational sac here. And so without the absence, when we look and we see absolutely nothing, we can be pretty reassured that this actually is not in the uterus. And so this is someone that actually needs to be treated with methotrexate. And you can see the polyps here that were making the lining really thick. And so her beta then rose, and she did in fact need methotrexate. So in conclusion, so similar slide from before, office hysteroscopy is safe and effective, and it's well tolerated, and it really is easy to implement. Once we figure out what you want to be doing in your practice. And I really think it's beneficial to both patients and to us. Some references, and we are now going to be open for some questions. I'm going to stop sharing here.
Hey, great. Thank you so much, Dr. Goodman, Dr. Isaacson. It's amazing how every time that I listen to a lecture of you guys, I learn so much. It's unbelievable. So we are going to start the Q&A session now, and there's been a lot of questions on the Q&A. And the first question that I was asked is, do we need to prep the vagina when we do this in office? I see you don't use you don't need to drape the patient. You don't use sterile gloves. Do you need to prep the vagina?
That's a great question. And that was a question that I had when I first started this. I don't prep the vagina. And I've kept track of every single one of these cases. I have a spreadsheet. Pretty much with everything I do, I keep track when things are new. And I have not prepped the vagina for many years now, in probably a couple thousand cases. I have yet, knock on wood, because now it's going to happen, but I have not had someone come back with endometritis or infection and need the use of antibiotics afterwards.
I do just put in a scopette with betadine for the sole reason that I can put it in my note that the vagina was prepped with betadine. I agree with you. It's not necessary. It's more for medical legal reasons in case they came back with an infection. That's the only reason I do it.
Right. I don't prep the vagina either. Keith, a couple of questions for you regarding the Asherman. One is, how do you distend the cavity? What is the pressure that you use? And the second is, after you do the lysis of adhesion, do you do any estrogen therapy? How do you prevent reformation of adhesions after you treat the Asherman?
The question about distension, and I'm glad Dr. Goodman said that she does have somebody squeeze her bag, because I think distension is important. And I use a pressure bag, and I'll, depending on the size of the hysteroscope and the size of your inflow channel and the size of your tubing, is the pressure that you need. So what you want is the minimal pressure that will give you adequate distension is the answer. So that pressure may vary depending on your system and your tubing. So with the system I use, I set it up to on the pressure bag, and I have this little portable pump that maintains the pressure. I set the bag on the pressure at about 100 millimeters of mercury, which translate to about 50 to 60 millimeters of mercury in the uterine cavity, the best that I can tell. But we don't really have an intrauterine. So I'll lower that pressure, keep it as low as I can to get adequate distension. Because particularly with a patient awake, the lower the pressure, the less uncomfortable they are. As far as estrogen, if a patient has normal estrogen levels, meaning she's ovulatory, there's a very good randomized study out of the Netherlands in 2020 that demonstrated that adding more estrogen was of no benefit. So if a patient asks for estrogen, I'm fine if she takes it, there's no harm, but I don't give it routinely postoperatively. Same with the balloons. The balloons right now, as you know, the Cook balloon is no longer available, at least in the US, and the Foley balloons only get the central part of the cavity. They don't get the cornua. So I rarely use a balloon. I will use something like a Mallinckrodt catheter if there's scar tissue just in the lower uterine segment. So which typically is where you find it when it's after a first trimester DNC. So I'll leave that in for 2 weeks with doxycycline, but no need for estrogen.
And always that second look hysteroscopy, right?
Yes.
How far apart you do the second look hysteroscopy after you perform the lysis of adhesion?
If I leave a catheter in, I'll do it 2 weeks after I remove the catheter. If I don't use a catheter in, anywhere from 2 to 4 weeks after the initial.
How about you, Dr. Goodman?
With the thought process being, that's when the scar tissue that's being reformed is still filming, and you can break it up in that time period.
Yeah, I generally do 4 weeks because I usually will operate between day 5 and 12 of the cycle, and then I will operate after if it's not complete Asherman's when they do have a cycle, and then we'll do it after the next bleed. So it's generally about 4 weeks.
What I will say with Asherman's, I'd rather them have as thick an endometrium as possible because I need to see what's normal endometrium and what's scar. And often in the early proliferative phase, it's difficult to tell. So that's the only one time that I actually prefer to do it later in the cycle so I can see what's normal and what's scar.
That's a great tip.
Keith, a good friend of ours, Amal Drizi, is asking the question that now that all the tissue retrieval systems are in vogue and everybody is jumping on them, you clearly said not to do a visual DNC, which is something that some experts are actually advocating for. Can you expand on that?
I can expand on. I'd love to have a debate with you, Tony. Maybe we can set one up.
Another one?
No, we already had our one debate. No, it's good to go out on top, so I don't want to do another one. The key is, I think if you're really an expert hysteroscopist and you know exactly where to stop, you can use any tool and you can use it safely. The issue is with the tissue shaving devices, they're side opening blades. So you actually have to push toward the basalis to get your tissue. And it's very difficult sometimes to know if you went too far and you removed the basalis and went into the myometrium. So I can just tell you, out of the 10 patients a week that I see with Asherman's, at least 40% have either got it from, most of them are from removing a polyp. Sometimes it's from these visual DNCs. So I just think it's not necessary. There's no benefit, and there certainly is potential for harm unless you're super, super confident in your skills that you're not going to remove the basalis.
Dr. Goodman, you show a very nice flow on the office and making the hysteroscopic procedure in office very effective. Do you have any tip on how do you arrange the flow of your office? Is this, you see these patients as you see the other one, you do all them all on the same day? How do you arrange the flow?
Yeah, So I put these in 30-minute slots in my, so, as a infertility physician, our day is set up such that we have a procedure doc of the day that does retrievals, transfers, hysteroscopies. And so we do have someone that is available. So we can see, and we also have labs in-house. So we're able to get HCG levels in-house. And so if we see someone early, we get their HCG level back and they're able to have a hysteroscopy that same day, really 30, 40 minutes later by the procedure doc. And so we are, opposed to a lot of MIGs where you have more regimented schedules. We are very fortunate in that respect. But I also will just, especially when I do my cavity evals with salines and HSGs, they'll come in early follicular, they'll come in on day 6, 7. And then if we see something, I'll just schedule them 3 days later, on day 9. And so I'll just fill them in gaps in my schedule, and they're in 30-minute increments, but I will double book them with something else because it really honestly takes less than 5 minutes. And so I'm able to, if I'm seeing a new patient, I'll see a new patient, and then while that patient's getting changed for her ultrasound, I'll pop in, do the hysteroscopy, and then go back to the other patient.
And then after the hysteroscopy is completed, do you leave them on observation for a while? How do you do that?
Because I don't use any anesthesia. I literally use nothing. And with my leader, when all these fluid was on restriction because we didn't have IV fluids, sometimes, I'd use as small as like a 60 cc syringe sometimes of fluid. And so it really doesn't take much fluid. So I'm not worried about fluid overload. And when I'm doing it with them awake, the whole time I'm talking to them. And so I'm very much, and I do, there are people that do not tolerate, the cervical extension. And if that happens, I've also aborted mission halfway through. If I'm worried about the patient and said, listen, like, let's come back and do this in the OR, or let's have you come back and get Cytotec, or have you come back and take some Motrin and a Valium ahead of time. So I am quick to abort if I need to, but I very rarely have to. And so when I'm talking to them about their results, they're like literally ready to get dressed and walk out of the room.
Okay. In the last 2 minutes that we have of this webinar, there is a very bad campaigns and bad hysteroscopy, people bad mouthing hysteroscopy, and the hysteroscopy should not be done in an office setting. So the question is, how do we counteract that? Spreading the word that actually it's a safe procedure to do, as we've been talking about it for an hour now. And also a couple of words about pain management. Paracervical block, ibuprofen, in 2 seconds, what is your pain management protocol, both of you? If you use any.
For me, all I do is ibuprofen. If I know I'm going to do a hysteroscope, is ibuprofen about 600 milligrams an hour ahead of time. Many of these patients are new patients. We don't even know we're going to do it. So giving it to them at the time, we don't do. Now, the paracervical kind of defeats the point of doing a vaginoscopy, only because many of these patients, what's uncomfortable is putting in the speculum, trying to avoid that. And we actually started a study where we compared paracervical versus not. And we stopped the study because most 60% of the patients thought that the paracervical hurt more than doing the procedure. So it's there, it's a backup. There's not one procedure that's great for everyone. But the key is telling the patient they're in control. Anytime they say it hurts too much and they want to stop, we'll stop. If they want to do it under anesthesia, we'll stop and we'll do it under anesthesia another day. So as long as they know they're in control, they're much more relaxed and it's pretty well tolerated.
Okay, we're at the time. Final message from both of you? Dr. Goodman?
I think that the key is that anyone can learn. It just takes a couple time, and find your reps, find your local colleagues that are willing to go with you. And I think if you can make it through a couple cases, you'll find that it's really easy to pick up. And so exactly what you said earlier, if you can do an IUD, if you can do an endometrial biopsy, you can do an office hysteroscopy. And I think the way that we combat the stigma that we're getting, around the world with this negative press is that we get better at it. And if we get better at it, then it'll be better tolerated and we'll do better for the patients.
Here?
No, and I agree. I mean, my point is, I think it should be a routine part of every gynecologist's armamentarium, whether they're a minimally invasive surgeon, a reproductive endocrinologist, or an oncologist. And there's not a urologist out there that wouldn't do an office cystoscope. There shouldn't be a gynecologist out there that can't do a office hysteroscopy. And we're getting there. I think we're making progress. And I would thank companies such as Linnea for making these tools that actually make it easier for our practice to offer this to the patients.
And again, I want to thank Lena for, taking this, sponsoring this webinar. And my final message is embrace hysteroscopy. There will be barriers, as I said at the beginning. Identify the barrier and overcome it. And you'll see that office hysteroscopy will be a very important part of your gynecology practice. With that, good evening. Thank you so much for joining tonight. And I'll see you around. There is a great Congress on hysteroscopy coming up in a couple of weeks in Barcelona. There is still a couple of spots available. I'll see you there, guys.